Then we put the spinal needle into this in the depression between L7 and S1, and we use what we call the hanging drop technique. So what we do is we put this epidural needle all the way to the ligamentum flavum, and then we stop. And this spinal needle has a metal catheter. You can see that here. So the metal catheter is then removed. The tip of the needle is on the ligamentum flavum. Then we inject some sterile saline into the conus, and we let the drop hang here. So this is called the hanging drop technique. And then we start to move the needle again. So then we take the needle and we start to move it through the ligament into the epidural space. And what happens if, as soon as the tip of the needle enters the epidural space, the hanging drop here will go inside. Because in the epidural space we have a negative pressure, a under pressure. So the saline is sucked inside. You can see that, and then we know the tip of the needle is in the epidural space, and then we connect our medication and we inject the medication. I think this is shown in this video. So here we have the needle. We don't need the sound, so look for this drop. There's our drop. Still the drop, and now it goes inside. Now it goes inside, sorry. Now it goes inside. Not so good to see on the, I can show you again, maybe, let's see this video again. And now we connect the medication and we inject the motoring. There it goes. And that's it, we take out the needle and it's completed. So let's look again and look carefully for the hanging drop. So we put saline in the conus and we start fiddling with the tip of the needle, try to feel the ligament. And then when we think the ligament is in or has gone through the ligament, now it goes inside. See there? There it goes. The fluid level goes inside. Then we know the tip of the needle is in the epidural space, and this should be without any problem. You should not have any resistance injecting the medication. So now look, is this the same? Yeah, it's the same. Don't want to say. Yeah, pitfalls. Okay. So actually, this dog, this was the second attempt. And when I prepared this video, right in the first attempt I had a problem. And so I thought, well, that's nice for St. Petersburg. So this was the first attempt. Hanging drop. And we start fiddling with the tip of the needle. And I do not see the liquid disappear. And now blood comes. See that? Blood. And actually, the clear water comes out. So what has happened is the tip of the needle is it's in the epidural space, but it has also entered the subarachnoid space in the dural end sac. And it also has entered the cavernous sinus. And that's why you get blood behind it. So, again, it's not a problem because this is the low back of the dog. So this is not a problem for the dog. After this we injected, repeated injection, and then, but you may get this. Here you can see the blood, which is not good. Then the tip of the needle is in the cavernous sinus, and actually liquid comes out, which may be blood, which may be the saline that you injected here, or it may be CSF from the dural sac. If you see this, you take out the needle, take a new needle, and do a second attempt. And this happens maybe 1 in 10 times. But it was nice that it happened for this video. So the question is this evidence-based what we are doing? Now, if you look into the literature for dogs, there's almost nothing out there that proves that this injection works for our dogs with low back pain. There's only one study, was published already in 2009, 10 years ago, by Luc Janssen. He's a Belgian vet, I know him well. And he did a series of dogs, I think maybe 30, 40 dogs, and injected them, and then followed them along after injection. The study is retrospective. The setup is not that good of the study. There is no control. And there's certainly bias in this study. So I put 2 big question marks there. Because there's nothing else there. Nobody is reporting. Everybody is doing it. Epidural injections with steroids. Nobody is reporting on it. At least not in a way that you can tell something from whether it works or not. So the only way to find some evidence is looking into the human literature, and epidural injections with steroids are also done in humans, and they are done a lot, and there's a lot written about it in studies, prospective studies with controls, comparing steroids with physiotherapy. And if you look at the literature, then the only conclusion is that there is not really evidence, or it's very poor, that it is better than physiotherapy or no therapy at all, or training sport in humans. So low evidence for steroid injections in humans, almost no evidence in the veterinary literature, and still we do it. Yeah, but that is the case with many things that we do. That is actually the reality. So we also thought about this, knowing that if we do epidural injections with steroids, we don't want to do that more than 3 times because of the adverse effects of steroids. So we were also thinking about something else with an injection. And also considering that we see a category of dogs that have clear low back pain, but with imaging we do not find that dramatic changes on the MRI. So for this group of dogs, we started working with intradiscal injections. So this is just work from the last 5 years. And we reserve this treatment for a group of dogs that is presented with degenerative lumbosacral stenosis, but only with moderate compression of neural structures and suspicion of discogenic pain. On MRI, they have early changes of the disc signal, and this is graded. This is a grading system for the water signal on MRI. And grade 1 is normal, grade 2 is slight, the start of degeneration, and grade 3 is clearly less water signal, and 4 and 5 is a black disc. So the early stages of degeneration, when they are visible on MRI, these are good candidates for intradiscal injection. And we use the spinal needles as guidance needles, and the important aspects of intradiscal injection is that the injection itself should be given with a very small needle, 29 Gs. Because if we use big needles to go into the disc, this in itself will already cause disc degeneration. And this has been shown numerous times in animal studies, that if you use a big needle going into a disc, this will start the process of disc degeneration. It's actually an experimental model of disc degeneration in rats, in mouse, even in dogs. So when you use this technique, essentially you need to take care that you do the injection with a very small needle. And these can be bought. These needles are not cheap. They're expensive needles. They are about 300-400 euros for one syringe and needle, but you can use it again. So that's the good thing. You can use that more than once. And for this injection, we need guidance by imaging, either fluoroscopy or CT, because it's important that the tip of the needle is exactly in the center of the disc. Okay, so let's, where am I? Yeah. So again, we have this scheme, the normal disc, and it starts to degenerate here. And so this is the dog that we are looking for. The dog before this stage of severe protrusion that is starting to hurt the nerves. We are looking for this category of dogs that is showing discogenic pain. So what we inject actually is experimental. It's not available on the market yet. So it's a NSAID. The NSAID is available. I mean, this is FDA approved. Celecoxib is an NSAID, which is FDA approved for use in humans. And this NSAID is packaged in a hydrogel or in microspheres and then injected as a compound into the disc. So the idea is that with that injection, to minimize the amount of celecoxib that you need to give, not by tablet or capsule, but by a dose that is put down exactly at the site where it is needed, and that you have a slow release platform from which the celecoxib slowly is released into its surroundings, there where it's needed for the discogenic pain. So, and studies have shown that in the case of spontaneous IVD degeneration, PEG2 is elevated. So the same principle as in joints. Also in disc degeneration, we see elevation of PEG2. We know from histological studies that we have nerve fibers in the annulus. We have elevated PEG2 causing pain in the disc. And that with celecoxib that you can get a decrease of PEG2. So somewhere along this line of this degeneration, we want to inject then our medication into the disc to treat the discogenic pain. This is just a slide showing you that COX-2 expression is also elevated in degenerated discs. So same pathway as for joints, COX-2 expression and PEG2 play a role in low back pain. These slow release platforms, they can be hydrogels that are thermoresponsive, meaning that at room temperature they are liquid. So these are smart hydrogels at room temperature, they are liquid. And if you put them at 37 degrees body temperature, or 38, they more or less solidify. They become firm. And if you package the medication inside this hydrogel, then once it is injected here in the disc, thank you. Once it's injected, it warms up from the body temperature, and then it solidifies. So it stays in the center of the disc, and then it can slowly release its medication. It's biodegradable. So these hydrogels and microspheres are biodegradable. And a lot of in vitro work has been done before we did this injection in dogs. We put out papers on this material, that it was safe to use in canines, but if you put not celecoxib, but BMP7, BMP7 is a growth factor. This is bone morphogenic protein 7. It's a growth factor that has shown in rats to regenerate the disc. But if you do that in dogs, you will not get regeneration, you will get new bone formation. And you don't want that. So this article showed that you should not inject BMP7 in canine discs. But if you use celecoxib together with hydrogels or microspheres, then at least in vitro, but also in experimental dogs, you can see that that it is safe, and that you may get a reduction in the pain scoring. So, in a clinical study that is now actually running in 30, not in 20 dogs, but we're now up to 25 dogs already, where we include patients with DLS, with low back pain. These are the inclusion criteria. Low back pain more than 4 weeks, unresponsive to conservative treatment, grade 2 to 4 Veerman scoring on MRI. These are the exclusion criteria. And in this study, we also have a placebo running. So at the moment that I'm injecting the medication or the substance, I'm not sure whether the medication is in it or if it's a placebo. And probably in this year, this study will be finished, and then we'll put that out in the literature. So how does it work? Here you can see the needle. This is the guidance needle. It's just a normal epidural needle. And it is positioned right on top of the dorsal annulus. And then, actually, it's very... No, I'll have later, I have images that shows you the very small needle. So this is the guidance needle. Actually, this is the small needle, but it's not so clear. I'll show you later. What we have shown in the follow-up in these dogs, that the injection itself is not harmful. So this is 12 weeks after injection, and the signal stays the same in the long term. 3 months after injection, we have the same stage of degeneration as before. And that was a big question, whether our injection would worsen the degeneration state. So this is just showing you the Veerman grading of this degeneration. I should have an image of that, but most likely, no, I forgot that. Okay, so grade 1 is, we have a clear distinction of the nucleus between nucleus and AF, so we have a nice water signal of the nucleus. Grade 2, the distinction is less clear. Grade 3, that is not clear anymore. And in grade 4 and 5, we have a black disc. So the distinction is completely lost, it's a black disc. And here we also have a collapsed disc space. So for the intradiscal injections, we select dogs with grade 2, 3, and 4. Most commonly the grade 2 and 3. And it can be microspheres or hydrogels that are loaded with this drug. So here's the needles that I'm talking about. So we have the very small Hamilton needles. So this is 29G. It's very thin. It's bendable, and that's why it doesn't work to use it from the skin, because it goes everywhere, this needle. So you cannot use it starting from the skin. So you have to guide this needle by a normal epidural needle. Also, this since it's very small volumes that we inject, and this is the injected volume is maybe 1/10 of a cc. It's a very small volume that you can inject into the disc. And this volume is then, these needles have a gas-tight connection that nothing will escape from the needle. So you need actually this needle for this intradiscal injection, which is a disadvantage, of course. So the epidural needle here is used as a guidance needle. This is an example. This is a 5-year-old Heidewachtel, had low back pain, unresponsive to oral medication, no neurological deficits. MRI showed a normal signal, minimal grade 2 degeneration. I mean, this is not dramatic. Many radiologists would say this is a normal low back, but this dog had quite severe low back pain. So this is a dog that was suspicious of discogenic pain. There's maybe even a video from this dog. This dog already starts to respond as soon as you touch the spine. Going further to the low back. Extension of the tail. And of course, we screened this dog for hip dysplasia, for stifle problems, for abdominal problems. This dog was a healthy dog, no deficits, and it came back and back with low back pain. So this is the dog walking. You can see nothing dramatic about this dog. This dog is walking normally. Maybe it has a slight kyphosis in the low back. Tends to keep its low back in a sort of a closed position. It's better to see on the side than front or back. See, slightly kyphotic in the hind. Nothing dramatic about this dog, but the owner could not do a lot of things with this dog because of the low back pain. Jumping was painful in the car, touching the dog was painful. So, and let me show you again this was the MRI of the dog. And this MRI was only made after the dog had numerous medications by the referring vet, by us. And then we are stuck with this MRI with a dog that is quite painful in this area. And I've seen numerous of these cases, and I think personally, this signal is not normal. I think there is a very small extrusion of the nucleus into the ligament here. That is an indication of degeneration. But that is my assumption. I'm not sure. Let's see. Okay, here another case, 7-year-old Labrador. This was a guide dog for the blind. And the owner, the client, complained of an unsure gait in the harness. Came to me several times, and every time the only thing I found was low back pain. And we did an MRI in this dog. In this case, we see some degeneration here. This is clear grade 2, grade 3 Veerman grade degeneration. There's not a whole lot of compression, slight bulging, but not a lot. This is the transverse scan. There's epidural fat around the caudine. There's no thickened nerve root. The foramina are still visible. So clinically, this dog has low back pain. MRI shows early signs of degeneration. This is a nice case for intradiscal injection. So here it's more clear how we proceed with the needle. Nowadays we do CT guidance with this injection. So here again we open the space by hyperflexion of the low back. And then we progress with the guidance needle. So this is the guidance needle right on top of the annulus, and then the smaller Hamilton needle, 29G, is progressed into the disc. And here we inject our intradiscal, our slow release platform. And this is just a little video that we made. The sound, we don't need the sound for this. The sound can be turned off. Okay. It just shows you how the procedure is in the clinic. This is still the fluoroscopy. This is the entrance of our clinic. So the patient comes in with low back pain. This is our MRI scanner, and if we have diagnosed the degeneration, here we see a slightly degenerated disc. Then it goes along to the either fluoroscopy or it goes to the CT scanner, and we prepare the site. And here we can see fluoroscopy. This is the Hamilton needle, locating the site. This is the guidance needle, and that smaller needle was the, so that is the stuff, the microspheres, and they're injected with this Hamilton needle inside the disc. And that can be done in a, so if I go back, there was one nice, here, this is what I want to show you. Now it's very clear. So this is our guidance needle, up to here, and the smaller needle, the 29G needle, that goes into the center of the disc. Okay, so is that all about chronic low back pain? No, that's not all, because I was telling you low back pain can also come from the bone itself. And there's even already an FDA-approved procedure for that in humans. And this, I just wanted to show you that low back pain in humans is a real issue that keeps people all over the world busy with finding the best treatment for low back pain. And in this procedure is focused on a tiny little nerve that goes to the bone around the lumbosacral area. Here we can see that this treatment is focused on the basivertebral nerve. So we're talking humans now. So this tiny little nerve goes into the vertebra of L5 in a human being, would be L7 in the dog. I'm not sure if this nerve is there in the dog. I don't know. I've not looked for it in the literature. But in humans, they found this nerve in anatomic studies, in histology. They found receptors of the nerve in the bone. And so they developed this treatment to go with a probe via the pedicle into the vertebral body and then do radio ablation of this nerve. I'm just showing you that this is a treatment that is out there, and it is even FDA approved, so humans can get this treatment. And before you have FDA approval in the States for a treatment, you have to show that it is effective, that it is safe. You have to have done animal studies, and they all did this, and it's now it is one of the treatments in a special category of patients with low back pain that do not have severe degeneration of their discs. And so this is, again, for a small group of patients. So they radio ablate this nerve. So this is the procedure going in with this guidance probe. They go in via the pedicle, find their way via the pedicle into the vertebral body, then center the probe in the vertebral body, then they go in with a device that gives radio waves, and they sort of burn the nerve. And if then on the post MRI images you can see these big holes in the vertebral bodies. I would not do this if I had low back pain. I would not do this. I'm not convinced that this in the long term is effective, but it is one of the treatments that is out there for humans with low back pain. So with that, maybe vision of the future, we'll conclude this talk, and there's certainly time for questions, I think. Anybody a question about low back pain?
Здрасте. Ага, спасибо за лекцию. Сколько максимальный срок вы использовали противовоспалительные средства нестероидные?
Okay, the NSAIDs can be used for 2 weeks, 4 weeks, longer even. As long as there are no side effects, you can keep on using NSAIDs. There's not, well, I mean, if you look at the paper in the which comes with the medication, it will tell you don't use it beyond 4 weeks maybe. But actually, we have dogs that are on NSAIDs for a year. If it is, if it's working and if the dog doesn't have any side effects, you can use it for long term. Not steroids. Steroids will give dramatic changes if you use it longer than 4 weeks.